You're having a mastectomy with an implant-based breast reconstruction. How many opioid pills are typical to be sent home with? So we always want our patients comfortable and happy after surgery. And for this reason, we have pretty extensively studied this exact scenario to figure out what our patients actually use and what they need. So in general, the studies that are done in this area, we give patients pain medicines and ask them to keep a log. So that's how the studies are done. We watch and see how many pain medicines they take and then over what period of time. Now, there was actually one paper that looked at all of the research published and based off of the results in all these different papers came up with recommendations. And their recommendations are exactly what you were prescribed. So if you are over 49 and have no history of opioid use, you're not currently using opioids, the current recommendation based off of all the literature in this paper is 10 pills to be prescribed to the patient. Now, if you are under 49 or have a history of opioid use or are currently using opioids, it's a little bit more, it's 15 pills. Now, this sounds really low, but remember, these recommendations came from patient-reported usage. We're not looking at patients and thinking what they need. They are telling us what they actually used. Large groups of women who had these exact surgeries said, hey, this is what I used, and this is where the recommendations came from. Why is this number so low? Because it seems very low, right? Well, because we've just gotten better at keeping patients comfortable. So opioid pain medicines are not our only modality to keep you comfortable as a patient. We have other things to add to the mix. By doing nerve blocks, you can reduce the need for opioid medicines by 40 to 60% in some studies. So just having a nerve block at the time of surgery majorly reduces your need for postoperative opioid pain medicines. And we have other medicines that we add to the mix too. So our goal is to make you as a patient as comfortable as possible. So whenever we talk about post-surgical pain relief, there's always naysayers in the comments that are like, just give us opioids, it's the only thing that works, we don't want those other things. No. So opioids are a problematic medicine, full stop. They just are, and we should be trying to minimize the use of them. And remember, we're not trying to minimize your pain control. We want you to have the same pain control. We just don't want you to have the complications and issues that are associated with opioid medicines. So what are these problems? So about 20% of patients that are using opioid pain medicines after surgery have an opioid medicine related adverse event. 20%, 1 in 5. That's pretty high. As someone who takes care of surgical patients literally all day, every day, nausea, constipation, are extremely common and they're extremely miserable for patients. Imagine having a DIEP flap or an abdominoplasty and being constipated. That's miserable. We don't want patients to experience that. So we try to avoid those things. And no, the goal is not to add an additional medicine to manage opioid-related constipation. It's to avoid the medicine that's problematic in the first place. And although developing opioid use disorder from a properly prescribed post-surgical prescription is rare, it's still possible. There's like a 1% chance of this. Every week you get your opioid medicines refilled after surgery increases your chance of an opioid use disorder by like 20 to 40% every week. So we don't want that to happen to you. And if we have other things we can add to the mix to keep you equally as comfortable, remember, there's no difference, equally as comfortable, we want to do that. My goal as a surgeon is to prescribe you interventions that get the desired result with the least amount of side effects. That's the goal. Now, all of that being said, if you as an individual patient are miserable, then you are not getting adequate or appropriate pain control. If I do all of the things I just mentioned in this video, you have the proper amount of medicines prescribed to you, but those medicines, number one, aren't working, or you need them longer, that's okay. Your surgeon will work with you or should work with you in order to improve your personal pain control. Sometimes I have patients that the typical things don't work, and so I alter my plan in order to make that particular individual comfortable. But whenever we come up with protocols, they're always based off of, the average patient, but not every patient's the average patient. So in my practice, I utilize all of the things because I want my patients as comfortable as possible. So we give patients Journavx before surgery and they continue it after. We have good pain control during the procedure. I use long-acting numbing agents and do nerve blocks. I give my patients NSAIDs, Toradol, Motrin, whatever. And in addition to that, they have opioids. And we figure out what works for that individual patient. With what I do with my ARIS protocol, my patients rarely take their opioids at all. So I also don't prescribe very many because I don't find that patients need them. Once in a while, I have a patient who has higher need of opioid medicines, and I give it to them because that's the appropriate thing to do. I'm so sorry this happened to you. It's absolutely the worst, most miserable thing to be recovering from a big cancer surgery and be in horrible pain. I wish your doctor would have done something different.